Endotracheal tube intubation. Oral endotracheal tube intubation is performed when the practitioner's skill and the patient's clinical condition permits. The practitioner lifts the laryngoscope handle until the vocal cords are visualized. The tube is inserted beginning at the right corner of the mouth. Primary placement is confirmed when the tube is visualized passing through the vocal cords. When correctly positioned, the tip of the tube is halfway between the vocal cords and the carina. The distal end of the tube is secured, and the depth of insertion is noted at the teeth or gums. The practitioner holds the tube to provide stabilization and prevent inadvertent extubation until the tube is secured. The practitioner ensures that there is no air leak and that cuff inflation volume is minimally occlusive. Nasotracheal intubation. Nasotracheal intubation is performed when oral intubation is not appropriate or is contraindicated, and when the practitioner's skill and the patient's clinical condition permits. Introduce the tube into the airway channel. Breath sounds become maximal just before entering the glottis. While listening, continue to advance the tube during inspiration. Inspiration facilitates movement of the tube through the glottis opening. Ensure that there is no air leak and that cuff inflation volume is minimally occlusive.
Monitor the child's vital signs and indicators of adequate oxygenation and ventilation before, during, and after the procedure. Ensure that the suction apparatus is functional. Connect the suction tubing to a rigid suction tip catheter. Have pliable suction catheters available. If time permits, comply with universal protocol. Perform a timeout to verify correct child, correct site, and correct procedure. Perform hand hygiene and don gloves, face mask, and eye protection. Assist with positioning the child's head. Position the child supine so that the oropharyngolaryngeal axes are aligned. Position the child's head. Infant, place the head in neutral position on a flat surface with the chin in the sniffing position. Older child, elevate the occiput to the sniffing position and extend the head at the atlanto-occipital joint. Child with suspected or confirmed spinal cord injury. Maintain the head in a neutral position with inline cervical spine immobilization. Open the airway and, using a bag mask device attached to an oxygen source, administer a sufficient volume of oxygen to ensure chest rise. Continue using the bag mask device to assist with pre-oxygenation. Administer intubation medications as prescribed. Apply cricoid pressure, Sellick maneuver, if directed by the practitioner. Once the ET tube is placed, attach the bag and assess the lung fields for air movement, symmetric breath sounds, and adventitious sounds. Assess for correct ET tube placement via stethoscope and capnometer. Assess for an air leak around the ET tube as indicated by the practitioner to verify appropriate ET tube size. Place a stethoscope on the anterior neck overlying the trachea with the child's head in a neutral position. With a manometer connected to a ventilation bag, administer positive pressure ventilation while auscultating for an air leak. Clean the child's face and secure the ET tube while the child's head is in a neutral position. Obtain a chest radiograph.